Welcome to the first of 4 classes in evidence-based medicine. This is the introductory module, which will introduce you to the PICO format of structuring clinical questions. I'm Professor Dr. Anthony Cummins from the Department of Family Medicine at RCSI Perdana, University of Medicine and Health Sciences. Before we start, just a reminder that there are several files that should be reviewed in the EBM core curriculum folder on Moodle, and also to draw your attention to this link to the Centre for Evidence-Based Medicine at Oxford University, which will provide you with lots of templates and tools to aid your understanding of evidence-based medicine. This is an outline of the class, and you will see it is peppered with case illustrations to outline the various principles that are in this class. When you've completed this class, you should be able to explain the underlying principles of an evidence-based approach to healthcare delivery, and specifically you should be able to structure a clinical question in the PICO format. You should also be able to outline the evidence base for common drug treatments, focusing on both benefits and harms. You will be assessed on these various learning outcomes in both end of rotation assignment portfolio, where you have to complete a specific EBM assignment, and also in the various components of the end of year assessments, including MCQs, key features questions, and also in the OSCE station. Evidence-based medicine is the both conscientious and judicious use of best available evidence in the care of individual patients. But this is combined with clinical expertise or clinical acumen, as well as the patient's own concerns and expectations, etc. Effectively, what this means is it is the application of the principles of population health or epidemiology to a single individual patient during a consultation. Underpinning this are 4 main principles or structures, and these are often referred to as the 4 A's: to ask, to access, to appraise, and to apply. So you begin by asking a structured and specific clinical question, and in this class you will see how this is done using the PICO format. You will then access various relevant sources of information, primary or secondary sources such as the Cochrane collaboration, PubMed, Dynamed, UpToDate, etc., to find information to answer this clinical question. You will then appraise critically this information for validity and relevance, and finally you will determine if this appraised information can be applied to your particular patient. These are 2 main players in the genesis of and development of evidence-based medicine, Dr. Archie Cochrane and Dr. David Sackett. It is in honor of Archie Cochrane that the Cochrane collaboration was formed and named after him. And David Sackett was the first professor of evidence-based medicine at McMaster University in Canada, and subsequently developed the Centre for Evidence-Based Medicine at Oxford in the UK. So why should we teach you those skills? Well, there are several reasons, one of which is that clinical performance deteriorates over time, and so students and doctors must engage in lifelong learning in order to provide ethical, professional care of their patients. And as knowledge changes rapidly, with a huge amount of papers being added daily to the medical literature, doctors need to be able to find, appraise, and apply evidence for patient care, often in real time during a consultation. But ultimately the goal is to provide improved patient outcomes, to improve patient safety by this triangulated approach of combining individual clinical expertise with the patient's values and expectations and the best available evidence. And the skills of being able to find and appraise relevant information with which to answer a clinical question is as essential as being able to take a blood pressure or to examine the cardiovascular system. And it is now agreed internationally that graduation from medical school should be conditional on students demonstrating that they can do these things by means of a year-end portfolio of critically appraised clinical topics. And we will do this, you will do this, during your 7-week rotation in family medicine. Let's look at a case. James O'Sullivan is a 45-year-old smoker who consults you as his GP with a 1-week history of cough and breathlessness. He has no significant past history, he doesn't take any regular medications, and he has no known allergies. He's further died of lung cancer. On examination, there's nothing remarkable, and you confirm a diagnosis of a chest infection and offer treatment for this. In addition, you also offer smoking cessation advice. But at this point, Mr. O'Sullivan tells you that his schedule at work is very busy. He doesn't have any time for this right now, and his priority is to get rid of this cough, but that he will return in the near future to take you up on this. So let's park him for a bit, but we'll come back to him later. How do doctors make decisions? What helps them to make decisions about diagnosis or about treatment choices? Let's look at the range of people and sources that may be helpful. Colleagues can be very helpful. You can ask a colleague if you don't know. Old-fashioned textbooks may be used. They may be slightly out of date perhaps, but still they're a valuable source of information. There may be a fear of litigation, particularly if a doctor has been sued previously. They may be a bit more cautious and hyper alert in the months or year after a successful claim, and therefore may over-refer or over-diagnose. The doctor's own prior knowledge will obviously be helpful, and also the decision may be predicated on whether the patient is a public or private patient. Doctors may turn to journals or to EBM resources and also various online sources. We mention here GP Notebook, now available as Quick Medicine, but there are also others referred to previously, such as Dynamed and UpToDate. There's also information provided by pharma sales representatives who come into doctors' clinics to inform them about recent developments and about their particular drugs and successful trials, etc. However, this information should be greeted with some caution, so we'll explain why right now. It comes down to the difference between absolute and relative risk reduction and how information, the same information, can be presented differently. And the question is, does it matter? I think it does matter, and let me explain to you why. Let's look at an example where overemphasis on relative risk reduction may exaggerate likely benefits of treatments. There's also a suggestion that overemphasis on relative risk reduction could also minimize the harms that come from treatments. So let's look at an example. This is a randomized controlled trial conducted on patients in hospital with acute myocardial infarction. These patients are already on an array of drugs such as antiplatelet drugs, ACE inhibitors, beta blockers and statins. So the trial is looking at an additional drug to ascertain if it confers any additional advantage over these other drugs. When the results were through, it showed that there was a 4% death rate in the control group and a 2% death rate in the experimental group. So the absolute risk reduction is just simple sums. It's 4 minus 2. So there's a 2% reduction. And the question then would be, would you be more likely to prescribe this drug on the basis of these results? And the answer is probably no, because the figures are quite low. If you present the exact same information in a different way, it can be much more convincing. We'll give it a name, Cure It All. And in big bold capitals, halves the risk of death after heart attack. This is exactly the same information, but presented as a ratio and giving you a relative risk reduction 2 divided by 4 rather than 4 minus 2. That gives you 0.5 or 50%. So this is true. It does have the risk, but it's a relative risk reduction rather than an absolute risk reduction. And would you be more likely to prescribe now on the basis of a 50% figure? Very probably. There are also other concerns about the pharma industry and their relationship to the medical profession, which is detailed here. So if you tease apart that relative and absolute risk reduction, it could look something like this. This is looking at getting a bargain in a department store at 25% off, but you may end up with only 2% off. Now, how can that be? Well, if you compare costs to risks, so cost of items to risk of developing an illness, you need to know the baseline risk and the baseline cost. In our example, we'll talk about risk because it's about risk of developing a disease such as myocardial infarction or risk of dying from myocardial infarction, for example. So it all depends on the background risk. If somebody has had a previous myocardial infarction, then their risk of developing a further one is much higher than somebody who's had no previous myocardial infarction and there's no other risk factors such as no premature family history, no obesity, no smoking, no hypertension, and no hyperlipidemia nor diabetes. So if you give, let's say, a statin to either of these two groups, you will get a 25% relative risk reduction, but the relative is the important point here. It's relative to the background risk. If the background risk is very low, then 25% of that is still very low. If the background risk is very high, then the reduction is much greater. And when you are reading papers for your EBM assignment, be careful, because when you see large figures of reduction like 20%, 10%, 30, 40%, they're almost certainly relative risk reductions rather than absolute risk reduction. It's very rare to get anything above single figures for absolute risk reduction. Now let's leave that for a moment and look at expert opinion, because a lot of medicine up to now historically has been based on expert opinion formers or gurus who are leading the medical profession in a particular direction. Let's look at 3 examples. This is an example of where theoretical suggestions were made and were offered as an explanation why a particular treatment should work. However, it did not work, but this wasn't looked at. The outcomes were not looked at until much later. So let's look specifically at this example from the US. In the 1970s, with the rising level of death from coronary artery disease, particularly myocardial infarction, a prominent cardiologist such as Bernard Lown proposed that as flecainide, a drug which prevented the continuation of ventricular tachycardia and its progress to ventricular fibrillation, could be very useful and should be given to all patients with acute myocardial infarction. This sounded very sensible and logical, and it was done as in several trials and in large-scale practice. However, when they looked at the outcomes, which is much later, they found that there was an increased mortality in those on flecainide as opposed to those on placebo. And in fact, if they'd looked at this much earlier, they could have saved a lot of deaths here. In the event, flecainide was responsible for the deaths of more adults that were killed in the Vietnam War. What about ignoring evidence? This is looking at thrombolysis for acute myocardial infarction, the use of clot-busting drugs very early on, as soon as possible after the myocardial infarction has occurred, in order to reduce infarct size and therefore improve survival. I'm going to show you a forest plot of thrombolysis, a systematic review of thrombolysis between 1969 and 1979, which showed very clear benefit. Let me explain the forest plot if you haven't seen these before. The forest plot here is a visual representation of a meta-analysis of a systematic review of several clinical trials. Here are all the individual trials by name and date and numbers of patients, and here are the representations of the confidence interval and the effect size in the square here in each of the trials. This line in the middle is called the line of no effect, and if the trial result is either side of that and clear of the line and not touching the line and not crossing the line, then that result is significant. And this diamond at the end is called the pooled estimate. It's the pooling of the data from all of the trials to give us an overall outcome result. And it shows clearly that in 1979, thrombolysis should have been continued as a treatment without any further studies being done. There was no need to do any further studies. Studies did, however, take place, and this is unethical and unprofessional because some patients would have been randomized to placebo at a time when we knew that thrombolysis was effective. Dr. Benjamin Spock was a famous American pediatrician who guided parental advice about rearing of their children and childcare in general. And he was very successful at this and wrote several books, among them this, his main book here, which is, you can see already in 1960 sold over 19 million copies. On the issue of baby sleeping position, Dr. Spock unfortunately was quite wrong. He promoted baby sleeping on their tummy, and there was a concern more recently that baby sleeping position could be linked to sudden infant death syndrome. This was a huge systematic review. As you can see, there are several studies here, and also it went on over quite a long time. It included studies from the 1960s right up to 2003. And what this showed was the position that was safest for babies was the sleeping on their back and not on their tummy. But Dr. Spock had said the opposite, and many parents had followed his advice. So if there is such clarity about an evidence-based approach to medical care, why don't many doctors work in this way? What are the barriers that they experience in trying to apply evidence-based approach to patient care? The most frequent one offered is time. They don't have enough time to do this. Some doctors have an attitude that this is all new, or as cookbook medicine or tick box medicine. And some may have had not been trained in this, both as undergraduates or postgraduates. For non-consultant hospital doctors or junior doctors in Ireland, and this may also be true in Malaysia, they, in addition to these, they have little power to influence change in the ward setting, as they are junior and don't have any influence over their seniors. So there are several problems with trying to invoke an evidence-based approach. First of all, there's such an explosion of literature. There's so many papers being published daily that a doctor would need to spend 20 hours critically appraising papers, and there simply just isn't the time to do that. The second thing is that in the rush of business, in terms of seeing patients frequently throughout the day, there is often unmet information need. There are clinical questions that are directly asked or that are separately considered by the doctor, but there isn't time to answer them. And we know also that there's a huge implementation delay between demonstrating the benefits of, let's say, thrombolysis, a baby sleeping position, and putting it into practice. On average, it is calculated the delay is 17 years, but you've seen in the baby sleeping position example, it can be a lot longer than that. So the solution to all of these three problems is to use pre-appraised summary reviews. These are already critically appraised for you, and they're produced by a variety of organizations, among them the Cochrane Library, the up-to-date Dynamed, also evidence updates, which comes from McMaster and the BMJ collaboration, and also PubMed itself. So effectively, the work has largely been done for you, and you can read these much more quickly than having to search for them yourself, and therefore you can do this actually in real time. Let's look at some examples of using evidence in consultations. These are two examples. One is the Ottawa ankle rule and the second one is the Centaur score, which shows how clinical prediction rules can be used in the clinical setting, in the consultation in real time. And this does not take extra time, it doesn't lengthen the consultation. The Ottawa ankle rule is for patients who have ankle injuries, and it is to determine whether they have high probability of a fracture and therefore require radiography, or they do not. And effectively, if the patient can bear weight and has no tenderness in the areas shown here, and also over the base of the fifth metatarsal, the likelihood of fracture is very low and they do not need referral to X-ray. Similarly, the Centaur score is a way of deciding in patients with sore throats which have bacterial infection and therefore require an antibiotic, and which do not require an antibiotic. And it's based on the following pointers. If it's an adult, there's no mark for age, but if it's a child under 14, there's a mark of 1, and then there's a mark of 1 for each of the following: exudate on the tonsils, cervical nodes, fever, and the absence of cough. And so it'll rapidly allow you to differentiate viral from bacterial. There'll still be a cohort somewhere in the middle who have medium scores. Low scores are viral, high scores are bacterial, and medium scores you have to temporize, and the generally agreed advice now is to give information from a source like patient.co.uk plus an antibiotic prescription that is dated 1 week later. So if the patient remains well during that week, they do not need to get the prescription dispensed. But if they remain unwell or become worse, then they should take the prescription the following week. There are a variety of clinical questions that arise in consultations, and these can be directly asked of you, or you may be thinking of them yourself as the doctor. Here are some examples. This is one on therapy. Here's one on diagnosis. This is a question about prognosis. And finally, a question on screening. So now let's look at structure in clinical questions using the PICO format. PICO stands for Patient, Intervention, Comparison and Outcome. Sometimes you will see patient replaced by population, and sometimes intervention is expressed as exposure. So it might be PECO. And occasionally you see an additional letter at the end, the letter T, for time. Let's look at a second case. This is quite a common situation in family medicine. A mother brings her 7-year-old son to see you. He has a right-sided earache for the last 3 days. There's been no discharge, but he's very distressed by the continued pain. He's otherwise well with no significant past history, and in particular no asthma. His mother has tried liquid paracetamol for the 3 days, but with little benefit as he's still in distress. So the mother's message to you is, he's suffered enough, doctor. I want to get it sorted. I don't want him to miss school. I don't want to have to come back here again and see you. So please give him an antibiotic. So let's now structure a PICO-based question around this scenario. So who are the patients here? Well, it's a 7-year-old boy and he's got earache. So there you go. School-age child with acute earache. Intervention, oral antibiotic. You don't have to specify which antibiotic, just antibiotics in general. And the comparison would be just symptomatic relief, for example, ibuprofen or paracetamol. You could also write in here nothing or placebo. And the outcome, well, the mum has told you what sort of outcome she wants to look at. She doesn't want him coming back to see you. She wants to get him better quickly because he's in pain, and she doesn't want him losing time off school. So the clinical question could be phrased in total like this. In school-aged children with acute earache, do antibiotics versus paracetamol lead to reduced reconsultation rates over the next 2 weeks, or earlier resolution of symptoms, or less time off school? Just to remind you, we will do a separate class on searching or accessing evidence in conjunction with the librarian, Mr. Hasbullah. Let's look at another case. This is the case we saw earlier on, Mr. James O'Sullivan, the man who you saw with the chest infection. And at the time you offered him nicotine replacement therapy for smoking cessation, but it wasn't a priority for him right then. He's now come back to see you, but he's mentioned that his friend Donald had also tried this from his GP, but didn't have much success. His doctor then gave him a separate drug called bupropion, and he found that was very successful. So Mr. O'Sullivan now asks you, doctor, can I have this instead rather than NRT? You're not quite sure if bupropion is as good as, or better than, or safer than nicotine replacement therapy, so you decide to structure a clinical question around this topic. So let's do that now. So the patient's here. John O'Sullivan is 45 and he's a smoker, so middle-aged smokers will do fine. Intervention, bupropion, comparison, nicotine replacement therapy or NRT. You could switch these around, it doesn't matter which way they go in. And the outcome has to be something tangible and something quantitative, and the general outcome would be long-term abstinence rates, and by long-term here they usually mean about 6 months. Most of the studies have conventionally mentioned 6 months as long-term abstinence rates. So the question now becomes, in middle-aged smokers, is bupropion more effective than NRT in improving long-term abstinence or quit rates? And there's actually a systematic review of that here. Questions about diagnosis are different because you're not giving the patient treatment, so therefore there's no I for intervention. The P is the same, population, but the I here becomes index test. Effectively, a question about diagnostic accuracy is comparing one way of diagnosing a condition with another way, the second way being the so-called reference or gold standard. And then the D is the diagnostic accuracy of the index test versus the reference standard. Let's look at an example to make it clearer. This is a study looking at uncomplicated recurrent cystitis or lower urinary tract infection in young women. So the population is women at least 18 years of age with this background, and in the absence of pregnancy, hypertension, diabetes, or renal disease. The index test here is not what you consider a test or investigation in a conventional sense, but it's their own self-labeling, their own self-diagnosis. Because they've had this recurrently in the past, they recognize the symptoms when they recur. The gold standard here is a blinded, positive culture in a hospital laboratory. And blinded is important here because the doctors performing this should not be aware of the origin of the urine sample. In other words, if it comes from a woman who's already self-labeled as a UTI or not. And when this study was completed, the diagnostic accuracy of these women's self-labeling was very high, approximately 84%. A question about prognosis is different again, in that you were looking at a group or cohort of patients or participants and following them over a period of time. They have an exposure to something. For example, it could be asbestos, and then looking at them over 10, 20, 30 years to see if there's a development of mesothelioma, for example. Another example would have been the Framingham studies that were done in Massachusetts and USA beginning in the 1950s, looking at the population of the town of Framingham and looking at their changes in blood pressure over time, looking at weight changes, BMI changes, and then more recently cholesterol, ECG changes, etc., to see if this led to disease. So for example, to look at those whose blood pressures were consistently elevated, did they develop more strokes over the next 20, 30 years? So in this case, you look at the population, the exposure, and then the outcome. Cohort studies can be done in two ways. They can be, the traditional way is the inception or prospective cohort. So you begin with the population, you look at monitor the exposure, and then you look at the outcomes at some future point, perhaps 20, 30 years hence. A retrospective cohort begins with the population who have a particular outcome or a disease at this point in time, and then you look back retrospectively at hospital and clinic records to see what factors emerge as possible exposures to developing this outcome. Here's an example of a prospective cohort which was done over a long period of time in the UK, looking at smoking history and outcomes in male British GPs. Screening tests are by definition are useful in detecting disease in asymptomatic or pre-symptomatic patients with a goal to identify disease when it is more easily treatable and therefore should lead to a better outcome. But since the majority of those screened do not have the disease, a negative test is of minimal benefit. But the disease prevalence is really important here, because as the prevalence decreases, the number of false positive screening tests may increase, and this may lead to the concept of overdiagnosis. So let's spend some time on this. It's an important issue. First of all, these are the criteria for a valid screening test. The disease should be relatively common, therefore the burden of suffering should be relatively great. It should be early detectable and should ideally then be totally curable as a result. The test itself should be accurate and valid. It must have few false positives and few false negatives. The test must be acceptable also to the population. So, for example, a blood test, a breath test is quite acceptable, but something more profound like a lung biopsy or renal biopsy would not be applicable as a screening test. And there must be demonstrable evidence that outcome is improved by screening early. Two examples where this is open to question are breast cancer screening and prostate cancer screening. Screening for breast cancer seems a simple and intuitively appealing concept. How could it do more harm than good? The idea is to find cancers earlier, improve survival, and minimize the need for surgery. However, things are not all so clear. Over the last 10 years or so, overdiagnosis has now emerged as the most important harm of breast cancer screening. It refers to breast cancers detected at screening that grow slowly or not at all, and therefore are no threat to the survival of the woman. And without screening, these cancers would never have been detected or would not have grown to a size or malignancy that would cause the patient a problem. So their detection and treatment therefore can only be harmful, because the woman may undergo chemotherapy, radiotherapy with all the harms that they can bring, and surgery also. There may also be women who don't have a cancer diagnosis but are diagnosed as such through screening with mammography or ultrasound, for example fibroadenosis or fibroadenoma. So the concept of overdiagnosis is increasingly important, and one of the concepts that have emerged is that in terms of shared decision making with patients, doctors should be aware, if possible, of the level of overdiagnosis inherent with a particular investigation, a screening test, and should inform the patients of this, and then they can decide whether they want to take the risk or not. This is an example from the Nordic Cochrane group looking at breast cancer screening and mortality, which did not show any significant difference between those screened and not screened. Let's look at sources of information now. Where do you get information to answer your clinical questions? This is a food analogy which is very relevant in Malaysia. Effectively, PubMed, or primary sources, are ways of finding out information about trials and reviews. And it's a bit like preparing a meal. If you're using PubMed, effectively you have to put in all the keywords and mesh terms and find the information yourself. You have to source the ingredients, in other words, and you need to plan and cook it. It's a slow process, but the results could be very good and very nourishing and very tasty. Secondary sources such as the Cochrane Library, Dynamed, UpToDate, BMJ Clinical Evidence, etc. This is high quality pre-appraised information already prepared for you. It's quick and reliable, and it may answer your question much more rapidly. However, information from these sources may not always be available. A systematic review on the topic of interest to you may not have been performed, and so you may have to go back and check through PubMed. So this is really useful and very practical, but you should also develop and hone your skills on PubMed searching, because you will need these from time to time. What about study design? How are questions, for example, questions on therapy? What sort of study design would be appropriate for a clinical question on therapy or treatment? Well, it's either a randomized controlled trial, a single trial, or better still, a systematic review of several randomized controlled trials, because the information from that is more reliable and more likely to be valid, and from which you can draw conclusions and apply the information to your patient. What about prognosis? We looked earlier on about middle-aged smokers. Let's look at a group who develop small cell lung cancer, and then you want to know the outcomes of the mortality rate over 5 years. So if you were to structure a study design around this, what sort of study would it be? So here again, to recap, middle-aged men, exposure to tobacco and lung cancer after 5 years. And this would be a cohort study, a prospective or inception cohort study. If you don't have time to construct a PICO, this is available on Moodle to be printed off and used in clinics. You can jot down the salient points and then check it out later on your smartphone or on your computer. Don't forget the 4 A's. We've added in the 5th A, sometimes people do. It's to audit and reappraise things after you have made changes and applied evidence to your patient. Then you might review that whole situation 1 year later. Also, be skeptical and curious. Just because something is published in a revered journal like these, don't assume that it's of good quality. Always be ready to ask, how do you know that? And don't forget PICO. I have some references for you here. Let's go through these briefly. This first one is from Students for Best Evidence. They're an Oxford-based group of medical students and others who have produced some very clear guidelines to understanding evidence-based medicine. There's also the Centre for Evidence-Based Medicine at Oxford with very clear crib sheets for doing critical appraisal. A very good underlying instructional tools and so on evidence-based medicine. And also JAMA, the Journal of the American Medical Association, also provides these JAMA evidence podcasts. I think they're now relabeled as JAMA Network podcast. The first one in particular, they're all on iTunes Store. The first one in particular I would urge you to listen to. It's from Dr. Gordon Guyat from McMaster University, and it's all about the genesis of PICO questions. It's called What is the Question? And finally, Testing Treatments Interactive is a UK source which is also very helpful and very clear at explaining. Thank you very much.